Welcome to Conversations on Healthcare. This week we welcome Dr. Joia Mukherjee, Chief Medical Officer for the global health entity Partners in Health, on the untimely passing of founder Dr. Paul Farmer and his vast imprint on the field of global health justice. Now, here are your hosts, Mark Masselli and Margaret Flinter.
We were all saddened by the recent death of Dr. Paul Farmer, and the co-founder and chief strategist of Partners in Health. Dr. Farmer and his colleagues pioneered novel community-based treatment strategies that demonstrate the delivery of high-quality healthcare in resource-poor settings. He wrote extensively on health, human rights, and the consequences of social inequality. He is even called a modern-day Albert Schweitzer.
Joining us to remember Dr. Farmer's contributions and to help us all think about how to advance his life's work is Dr. Joia Mukherjee, the Chief Medical Officer of Partners in Health, which has the wonderful tagline of "Injustice has a cure."
Thank you so much for having me.
Yeah. And really, we appreciate you taking the time to talk with us on this really sad occasion. And let's start with your personal memories of Dr. Farmer. What sticks out in your mind?
Yeah, I mean, I was just talking with a friend just before I joined you, and I think what sticks out most is that Paul was incredibly funny and fun to be around. And I think the reason that sticks out so much is that the work of social justice is incredibly difficult. Mm-hmm. You have to not only minister to the sick and the poor, but you have to really dive in and recognize the history and the reasons for the injustice. You know, justice itself is really a retrospective concept. You have to understand that harm has been done and what those forces are. And Paul's great gift was to do that hard work with so much lightness and effervescence. And he did that really through humor and love. And it was so generously spread to everyone. We all have thousands of inside jokes and pet names for one another. And I think that bound us together through really difficult times. And it shows the way that, you know, contributing to social good can be actually joyful, even in the dark times. And I think that, to me, is what I've been really coming back to over the days since learning of his death.
Well, that is an incredible legacy, and I'm so glad you raised that very human component. Thank you for sharing that with us. You know, one of the things we've come to understand is that Paul Farmer reshaped our understanding of what it means to treat health as a human right, and also the ethical and the political obligations that follow once you recognize that. Tell us a little bit about how specifically did Dr. Farmer accomplish that goal?
Yeah, I think, you know, we live in a world that has deeply structured inequalities along the lines of race, nationality, gender. And so when I started, and many of us, and the sea change we all witnessed because of Paul's vision, was there was an acceptance of those structural inequalities as normative and as unfixable. And so the general thought was country X has $3 per capita for health, and you have to just do whatever fits in that ceiling, rather than asking, why is that ceiling there? How do we break through it? And then the most important question of all, what is it that the person in front of you needs? So obviously chemotherapy never fell under that ceiling of $3. HIV treatment didn't, palliative care, orthopedic surgery. So in accepting that inequality, that economic and social and racial inequality, you will never achieve health as a human right. And so what Paul challenges all of us to do, even in death, is to treat every person as if you would your own family. You wouldn't say, well, we have $3, this is all we can do. In fact, I've seen impoverished people walk miles, expend huge amount of resources, sell their own assets, home, animals, just to get care for a child. So the $3 is never enough. And we should never think that we can provide healthcare as a human right without massively looking at these in unequal structures. And Paul called that structural violence. And indeed, it is violent. And I think that is really his greatest contribution.
Well, what a nice conceptual model in really framing up sort of the focus of the organization, Partners in Health. And I guess it's perhaps an inflection point. I don't know where you all are, but I'm wondering if you could share with us where do you go from here and how do you keep Paul's promise moving ahead? And can we assume the focus will remain on community health in countries where you serve and not, quote, parachuting in strategy when disaster strikes?
Yeah. Yes, you can assume that we will stay and double and triple down in the communities and the countries we work in, helping both the communities and the public system. I mean, Paul really believed in the public provision of healthcare, not a charity alone, but that, the right to health depends on the public provision, strong governance, and community participation. Mm-hmm. This is really the dialectic of human rights that is so critical. And so, we will be doing that. One of the things I've been saying a lot is that Paul really left us a roadmap. He wrote about what he wanted all of us to do. He spoke about it, he taught it, and he modeled it in his own practice. And so I think we're very clear that our job is always taking care of the poorest of the poor, but at the same time strengthening government systems, working with communities, and teaching the next generation. And, he died in a university where we have worked together with partners on the ground, the University of Global Health Equity in Rwanda, teaching our first class of clinical medical students. He had been there for 6 weeks. And we know that one of the most important things to Paul and to all of us, in fact, is to really continue to provide formalized long-term treatment to improve healthcare, not only for people, but to assure that their providers are local people who speak their language, who are from their communities. And so that is what we are committed to doing: care for the sick, training the next generation, and working to build robust public systems and engage communities.
Well, I think a great example of that was some of his work throughout this COVID pandemic. And we remember that one of his major acts was really pushing the Biden administration to drop intellectual property barriers that prevented pharmaceutical companies from sharing their technology. And I am sure that COVID is not the only example we could look at of this. Maybe share with our listeners why that still matters, and where does that effort stand today in a broader way as you talk about making sure these treatments are equitably available to people?
Yeah, thank you for that question, Margaret. Paul strongly believed that there should be goods in the public common for things like health, for education, and when we see what's happening with the, a vaccine apartheid, as many are calling it, there's still less than 10% of people on the African continent vaccinated. We know that Omicron probably came from unvaccinated populations, as did Delta, as will the next variant. So most importantly to us, it is moral for everyone to have the fruits of science, not for those fruits of science to be again put along these structured lines of inequality. But in addition, it's in our global interest to work together and collaboratively to end a pandemic, not in a nationalistic way. We cannot be a fortress. We know that. And so, Paul felt very strongly that the scaling up of vaccine production, he was very committed to the plant that is starting to produce vaccines in Rwanda. He had just visited there on his last trip. And through collaboration with pharmaceutical companies, with governments, that we should really expand massively to 22 billion doses, actually, the availability of the mRNA COVID vaccine.
You know, I'm going to pull the thread on the word collaboration, because it's interesting that he advocated for working within existing power structures, even if they were disliked, such as with the World Bank. But he also felt all right getting comfortable with discomfort. And how do you and your organization square these two beliefs?
Yeah. Well, Paul had a term that we've all come to be very familiar with and use a lot, which is the notion of pragmatic solidarity. Mm-hmm. You can be in solidarity with the poor and really kind of despise the power structure, really be questioning this structural violence and these structured inequities. And yet, when we come face to face with someone suffering, we need to get whatever tools we can to help them. And so the pragmatic solidarity says you can critique and work on these bigger systemic changes, but to deliver care, to save, to palliate, you've got to do whatever it takes to get to that. And so that is our notion, is to remain honest critics, but also try to collaborate to get the work done at the very human level that it needs to be done. And we've been able to do that. Sometimes it's not easy. Sometimes we have to have, different strategies. But at the end of the day, the most important people to us are the most impoverished people who are sick.
Well, Dr. Mukherjee, I know education is a huge interest and concern of yours, and we know you as the author of the widely used textbook and introduction to global health delivery, practice, equity, human rights, and we understand somehow you've also found the time to get a second edition coming out with a focus on pandemic. So what will our readers learn from you about this incredible time in our recent history?
Yeah, thank you for mentioning that. It's not something I think a lot about at this time. And the second edition is out. I think one of the reasons I was asked to write a second edition is so many of the principles in the first edition of the textbook is how do you build the staff? How do you improve the systems? How do you look at drug supply? All with a mindset that you want equity as the end result. And what we saw in the pandemic that was so jarring is the failures of even the richest country in the world, the United States. And I think trying to understand that it's not just about money or inputs, it's about systems that are designed with equity in the first instance. And so a lot of it is talking about how do you look at equity? How do you think about collaboration with people from different cultures, different countries? How do you put the poorest people first? Had we done that in the United States, we probably would not have the pandemic that we do. And indeed, when Partners in Health was asked to support the public health department in the state of Massachusetts, our big, I think, most important contribution is to do contact tracing. Not so much. But for each person we talked to, we said, these are the things you need to do to protect yourself and your family. Can you do it? And if the answer is no, then you need social support, food, eviction support, all of these things. That is how you build a program with equity. If you're just telling people information, that's never going to be an equity-focused program. And so a lot of the work in the second edition is to say, how do we, in a pandemic, recognize what has happened with these structured inequities, and how do we fight to deal with that worsening inequity at a time such as this?
Well, that's such an important note of having that lens of equity as a focus, and also translating that past its importance, but into really practical terms. Clearly, there's a noticeable feeling of relief across the United States right now as Omicron variant seems to be waning. But how do we keep Americans alert to the pandemic's really continuing threat in other parts of the world that have a lack of vaccines and treatment? And we know this is a global need, and I think Americans tend to perhaps be narrow in their focus about what it means to have a solution here.
Thank you. I mean, I think if there's one thing that I and many of my colleagues, and certainly Paul, lose sleep or lost sleep over in our lives, is how do we get people to care about our shared humanity? I mean, in COVID, you'd think that even just the fact that it's a threat, a continuing threat to all of us would work, but we see that doesn't work. That's not enough. And what I've seen in Ebola and HIV and the other pandemics and epidemics I've worked on is the threat of contagion just tends to kind of serve to otherize people, build more walls, close the airports, right? Whereas trying to bring forth our shared humanity, this is a mother, this is a friend, this is a person whose life has infinite value. That I think is the way we have to go. And I don't see a lot of leadership in that space right now from the global north, but I do see it from, the global south, from African leaders, like Cyril Ramaphosa in South Africa, like President Kagame in Rwanda. And so trying to think about how do we foster that? And what gives me hope is young people. People under 25, they really understand this in a very different way. I don't know if it's their connections across boundaries. They're much more tuned into the world as their peer group. And so it's my hope that that will help us sort of promote this.
Well, we couldn't agree with you more about our just incredible pride in our young generation coming up and the work that they are doing and going to do. But one of their challenges, as it's been a challenge, I'm sure, for your organization, has been at any point in time, so much going on in the world right now.
Yes.
What we are witnessing and what people in Ukraine are experiencing, so many challenges. How do you prioritize where you're going to devote your efforts of people and resources? Is it even right to talk about prioritization, or does the most urgent kind of triage rise to the top of the list? Just share with us a little bit about how your organization approaches that.
Well, we have the feeling, and our very name, Partners in Health, is that there is no movement that can happen alone, right? That there's no social movement ever that has been a homogeneous group. And so we want to do what we do well, which is take care of the sick, but we invite other people to join us. We have close collaborations with the Equal Justice Institute that is working on, death penalty reform and cases. We have close collaboration with Mass Design, which is an architecture group. We've worked with prison reformers. And so I think if we think that the goal is a better and fairer world, it's going to take lots of different kinds of organizations with whom we are always delighted to make common cause. Some of my great friends and fellow travelers, from my life have been HIV activists. So I think the way we look at it, and what I tell young people that I teach, is do what you do well, do what you do with a passion, and then try to find collaborators from different walks of life to share that journey. And, I am a doctor, and so I try to do doctoring. I'm a reasonably good speaker, so I end up in front of, crowds. But there are people who are phenomenal at trying to do financing, and they're working on that. There are people who know a lot about water and sanitation. There are people who know about peacemaking. And so, that's my view of the world, that we all have a part in it and can work together.
Well, that's a great vision. Thank you, Dr. Mukherjee, for all that you're doing. And we appreciate your insights into the life and work of Dr. Farmer, and also the incredible impact that Partners in Health is having around the globe. And thanks to our audience for joining us in this important talk. And you can learn more about Conversations on Healthcare and sign up for our email at chcradio.com. Again, thank you so much.
Thank you so much. Thanks for having me.